Great, thank you all for joining us tonight. We have a great panel and a great agenda to walk through. Recently, CrossRoads has introduced the new DynaMet Lesser TMT system that Dr. Evan Young will walk through and introduce, recently launched only 1 month ago. To go along with that, Dr. Shawen will introduce the DynaBunion 4D Lapidus system and his clinical experiences with DynaBunion and Lapidus. We'll hit a few key clinical topics such as soft tissues, frontal plane deformity, and 3 and 4 corner spot weld fusion techniques. We'll close this out with some case reviews and a few panel topics and Q&A moderated by Dr. Miller. And with that, I will hand it over to Dr. Young to start us off with DynaMet.
Thank you very much. Yeah, I've loved using this DynaMet system. It's a very impressive system. It definitely speeds up the process, and you'll see why. The DynaMet system really was designed as a complementary system to the DynaBunion system, which is sort of the jumping off of the or flagship for fusion of the midfoot for the CrossRoads line. They do have a really nice set of instrumentation, as well as ways to correct deformity in all 3 planes, which we'll talk a bit through. So what does the DynaMet system actually consist of? So it's what they're calling the slice and vise technology, which is basically to prepare the joint rather quickly and then compress it together with unparalleled compression and dynamic compression that stays. So you get all the technology that goes with the DynaBunion system, the staple compression plate, and you have several different options for how you want to plate this. Whether you like linked plates or individual plates, longer staples, shorter staples, if you want to step off, they're all good options there. Like I said, it's meant to go together, but it doesn't have to. So the DynaBunion was awesome, but they didn't have anything direct for the 2nd and 3rd TMT joint at the time. Now we're introducing this way of correcting either distal bunion issues and then still coming back to the midfoot and fusing, or if you just want to do all midfoot, or even just a Lisfranc fusion for either post-trauma and any of that sort of stuff. It's all ready for you. So the slice and vise, the idea is that you rapid precision cuts, simple alignment, and strong permanent compression. The staple compression plates, we'll talk a lot about how they provide gap recovery, apposition, speed, and all the typical things you're worried about. So the staple compression plates do a great job of having post-operative compression. They also get 100% joint apposition and axial compression with a dorsally located plate. So it's an impressive system. Like I talked about, the apposition is probably my favorite thing, and the thing that got me started on this, which is the lack of a screw sitting across your joint, taking up half your joint space. So that's the part that drew me in initially. Speed of use is really impressive. So here's how the staple compression plates work, because a lot of people kind of get focused on the fact that we're using a staple inside of a plate. And if you see here, this is a static plate with a static screw. You may have had great compression, but over time, as the bone resorbs, you're ending up with a gap between the joint surface. So this is the staple with the staple compression plate. And you'll see as the ice between the blocks melt, which it simulates the bone resorption for fusion, you'll see that gap recovery takes place with the staple. And it's really quite remarkable. There's a axial force that allows it to slide, which is what you're seeing here with the staple before and after the compression takes place. So you gain quite a bit of compression, and the sliding of those screw heads is what allows for that. Going on. So these are your different plating options. It really does provide great options. They're really contoured nicely. Everything seems to fit every time you try to put something on. So there was a lot of good engineering that went into this. And you just never know when you get in there what you're going to need to have. And if you need an offset hole, or you want to get a better angle, sometimes you want a linked plate, sometimes you just want a straight plate. And so you have all those options available. We're going to run through the surgical technique. Basically just easy dissection right here, right over the second and third tarsometatarsal joint. You want to get all the way down to bone. You want to take off any dorsal spurs so that you can get access to the joint and see where you're at. Use an easy compression, or I'm sorry, a cut guide here at this point. It has holes that are designed for your compression later on, but they'll do a nice job. These other angled ones can kind of help keep the plate or the cut guide down as you're trying to cut this bone. You can use these nice little slots here to kind of keep your blade from too much excursion and getting into the other joint, since it is a 40 millimeter long blade. So the most you'll ever take is 1.6 millimeters, should be just enough to get the subchondral plate off. You just flip it around, use the same pin, put a second pin in, and then you can cut the other side. And then your prep is pretty much done if you like flat cuts. Now, if you want to continue to prep the joint, you can do so by distracting the joint out. They add a Hinterman distractor. You can use a small drill bit if you like doing it that way. You can also use a osteotome to kind of fish scale the area. But this is really nice because now your same pins that were used for your cut guide have now been used for your Hinterman distractor. And now it's ready to compress after you've gotten all that set up. Lots of different options. Here they're showing the 2 straight plates versus the link plate versus the individual compression staples. So these are just showing you the different sizes of the plates and staple combinations that you can go through. Here's the nice contouring. Coming with these natural bends, which really just helps them sit nice and flush. And they do have these templates, which are really nice, so you don't have to open all the plates. You can look at the template. So the system is a little different if you're used to DynaBunion. Just kind of we go through a little bit of a different set of directions here. This is how you know which plate you're going to put on. And they do use those Hymax Plus staples, which are really nice. So your olive wires, or these wires, should fit over those 2 pins. They have every time that I've ever used it. You use the olive wires to hold it in place. You have all these different screws, not locking and non-locking. I always start with 3.0 and then advance to 3.5 if I'm not getting much purchase. So you'll put in the 2 most proximal screws first. Ideally a bicortical purchase. Once those screws are placed, now you're going to get your compression. So this is where those compression blocks come in that are so nice from the DynaBunion system. And you put your 2 compression blocks on so that you can compress the joint. If you need more compression, you can go up to a 1. There's even a 2 in the DynaBunion system. So that's kind of nice to get even extra compression. You place the distal screws. So now you've got provisional fixation and some compression on the joint. And then you can add more or you're going to add more dynamic compression right here as you place the staple. So your staple's not having to go to work already, which is kind of nice. So you're gaining that dynamic permanent compression until the joint fuses. Place your staple. Once you're happy, make sure it's good. You tamp it into place. Place your second one, and then you're done. Really does speed up the process. So I'll turn this over to Dr. Shawen and let him discuss the next portion here at DynaBunion. Anyone make sure you get off mute.
Hey, Dr. Shawn, I think you might still be muted from our end.
Sorry, I was muted. Sorry about that, guys. Going back here, just starting up again, the DynaBunion system's been around for about 18 months now. And so we really do believe in the 3D correction so that you get correction in all planes. Let me see if I can advance this here. So when we look at this, you have your transverse or intermetatarsal angle. You have your frontal, your seismoid. So that's that rotation that you see in that lower right. You can see them rotating up and decreasing that intermetatarsal angle, as well as the rotating along the coronal plane there, and then your sagittal alignment, which is the alignment of the metatarsal relative to the rest of the foot. So there's a lot of systems out there, and what we've tried to do is create a system that is simple and stress-free, but also consistent. So it provides you the same product every time. So it takes the same cuts and provides you that correction that you're looking for. And so, one of the things that we also want to look at is, how do we get this correction and then also get some healing to occur? So that's where compression comes into play. CrossRoads entered this segment really looking at just staples years ago, but then they came up with a hybrid staples and plates together, and then developed this system that provides you, again, a consistent reduction and correction of your intermetatarsal angle and rotation and correction, but also provides you continuous compression that Dr. Young went over in the previous video. One of the main things that we look at here is this 4D rack block. So what's happening is that you've done your cuts and these wires have been placed while you're doing your cuts, but when you place this rack block in place, it actually provides compression across the fusion site before you even put on any fixation, whether it be the staple or the plate itself. And so the staple and plate then provide continuous compression after this. So the C4 technique, again, this is cut, correct, cut, compress. And then, we've got compression for essentially forever as the staple continues to compress. I've got a blank screen, guys. Am I correct here? Okay. So we're just going to go through a video here, and I'll try to narrate a little bit as we go. So we're getting the reduction as far as the rotation, your intermetatarsal reduction, and then locking down your alignment, and then compression. So incision-wise, it's a dorsal medial incision. We've made this a little more dorsal over time. And again, as you do more of these, you can make the incision a little bit smaller. One of the main things that you need to do is open up that joint so that you can get this cut guide in place. It has a blade that you need to place into the TMT joint. And so notice that the saw blade is vertical to the metatarsal, not vertical to the cut guide. That makes it so that you don't cut into the second metatarsal. Now we look at this, and we're going to be able to rotate this metatarsal and correct your coronal alignment. So correct that pronation of the first ray and reduce that, and then hold that rotation with your essentially clamp here, and then you can correct your intermetatarsal rotation. So what that's doing is you've already done a minimal cut on the base of the first metatarsal. Now you're going to do a minimal cut that is in line with where you want this metatarsal to be. And so again, the cut is vertical to the metatarsal, not vertical to the cut guide. That prevents any cutting into the base of the second metatarsal. So if you have to recut because you have an atavistic joint, something like that, that was a recut guide. They also provide a hinterman so that you can get into the joint and prepared, just as Dr. Young talked about. Usually you're through to the subchondral bone at this point, but I usually do drill. It provides some shavings into the joint, and I feel a little bit more secure about this. This is placement of the compression block called the rack block. Again, this provides compression at your site before you even place any fixation. So I usually keep the rack block on while I'm placing the staple and the plate medially. And so there are times, however, if you need to remove the rack block, they've already thought through this. You can do some accessory pinning before you remove the block itself. I use a rongeur usually, but they do provide a kind of a cheese grater to remove the eminence medially. You can also have several different plating options. You can also bend the plate as needed in order to fit the contour that you would like. I do typically place 2 olive wires, and then I place the staple at this time. I usually, before I remove the rack block, can place the screws distally and proximally, one on each side. There are staple options, as they showed, that have a 14 millimeter leg if you're concerned about the intercuneiform area in order for that leg to not enter into that area. There's also multiple fixation options. I do stick mostly with 3/5 non-locking screws in this because I want the plate to be able to move slightly as the staple provides some compression. So again, I usually put a distal and a proximal screw before the rack block is removed. And then this is usually a cortical screw that has fairly good a bite in that area. And then again, you'll place your cuneiform screws. Many times I will leave one of the cuneiform screws longer. I feel that that provides a little more security and patience with softer bone. This is the anti-drift bolt. So what we're trying to do with this is maintain that intermetatarsal angle with this. You're not reducing the angle further because that's already been done with your clamp distally. This is just holding it in position. You do want to make sure that you get to the lateral cortex of that proximal second metatarsal in order to have as much purchase as possible. So that's essentially your overall construction. Now you can, if you like to do free cuts, you can do that on just with a free sagittal saw and prepare your joint however you would like it. They do have a pre-cut guide, which now will allow you to compress at that joint after you provide some rotation. That handle is a very strong tool for providing your coronal correction. The 2 other wires are again then placed, and then you have your rack block, and you would proceed from there. So as far as the key clinical tips, I think we went through most of them during the video. The main thing is that start with a slightly larger incision and then go on from there. And I'll turn the time over to Dr. Miller at this time.
Hi there. I just want to talk briefly about balancing soft tissues. And the big question is, what do you do about the first MTP joint? When do I do a lateral release? When don't I? And what do we decide to do? And this comes from an old guy who used to always do a big lateral release because I felt I had to free everything up. And in reality, I don't know if I believe that anymore, especially with my experience with the mini bunion. I get awfully good mobility without interfering with the capsule at all. So I'm going to ask your opinions about that too, Evan and Scott, but I tend to go in if it's a really bad hallux valgus and that hallux valgus angle is huge and things are stuck over there, then I might have to release the capsule, might have to release the lateral metatarsal seismoid ligament, but I try not to if I can help it. And a lot of times for TMT arthritis, the first MTP joint isn't that involved, but for a bunion, a lot of time it is, and I do as small release as possible to get my seismoids back underneath. And if they're relatively in the right position, when I look at my AP, after I correct my rotation, I don't do much of a lateral release at all. but I think everyone's supposed to take this. It's a learning curve, and I'm curious, Scott, what do you think about it?
As far as the lateral release, I'm probably about 50-50. I see that there's a beaver blade on that, and I have done some a fair amount of percutaneous lateral releases. Again, it all depends on how tight that toe is. I do find that on really, really tight toes, I get a little bit scared because you really have to get that blade plantar and essentially release off of that plantar lateral phalanx.
Yeah. I don't mind opening it up, but I'm just not sure how much I need to do anymore. Evan, what do you use your guidelines?
Yeah, I completely agree. I think I get everything corrected, and then I assess the MTP, sort of, planning on either Aiken or a lateral release, and right at the end of the procedure, just to decide, how much balancing we have to do, how much lateral pull that has. I try to see how much overcorrection I can do at the MTP and stretching out the soft tissues. If it feels tight, I'll do a release. But I kind of agree with you. I do these less and less as I get better and better at seeing how much correction you can get with the DynaBunion in all three planes. And I just don't find myself doing them as often anymore. I probably used to be 50-50. I'm probably less than 25% now.
That's about where I am, but I do it on a case-by-case basis, but I don't do anywhere near the release I used to do. I don't think I need to anymore.
Yep, I agree.
Let's go on.
So I'm going to discuss the frontal plane issues and how that gets corrected here with this system. And you really need to assess this, based on the big thing for me is the crista. And sometimes if those seismoids have been working their way laterally over a long period of time, the crista can be pretty flat or non-visualized even. And if you get an axial view, that can help here on the MRI and the cadaver slice here. This is really nice because you can see kind of the clockwise configuration of the metatarsal head and what you're looking for. As far as that goes, and you really do need to get those seismoids back underneath that metatarsal. That becomes a critical part of the procedure for longevity, in my opinion. Here they've even got them graded out. I think there is something to be said for soft tissue contracture and the age of the bunion and those sorts of things. Those play big roles in how much reduction you're going to get. Sometimes you can just turn the metatarsal, which really works the majority of the time. But sometimes you really do have to do additional procedures to get those metatarsals or the seismoids back underneath that metatarsal. I don't know why that keeps jumping ahead too. So obviously you have your tibial seismoid position that we all learned in school from 1 to 8, and you really want that seismoid position being in the proper location there. Here's where you can kind of evaluate on an AP. You can kind of see that lateral portion of the metatarsal head that looks rounded on an AP when it's rotated. When it's rotated back into the correct sagittal plane, it looks a little more squared off, which really helps is from an AP view to see how much frontal plane issue you're going to be dealing with. Sometimes you'll even see that big concavity in the mid shaft of the metatarsal, which can really be a sign that you're dealing with a lot of frontal plane as well. So I'll turn it back over to Dr. Shawen for the fusion technique.
And so, as we discussed about this and tried to figure out, what's the best way to get a long-term fusion, because in my institution, we initially saw with just a TMT arthrodesis by itself, you could have initially a great correction, and then over time lose correction or lose your reduction. And I think a lot of that occurred between the essentially the base of the medial cuneiform second, as well as the intercuneiform joint, and you would see that widen over time. And so we went back to some of our colleagues that have done a lot of Lapidus fusions over the years, and Dr. Anderson in Michigan he had published with this with Dr. Bohe as well as others, looking at how can we increase this. And so they discussed doing a 3 or 4 corner arthrodesis. And so, as we looked at this further, we wanted to figure out, well, can we do a 3-corner arthrodesis through this incision? I think a 4-corner is probably a little bit more difficult to do without some sort of dorsal incision. And so, looking at this, that's where you get into the intermetatarsal as well as intercuneiform fixation. Sorry about that. And so another article that was published on this, looking at, first TMT fusions and then applying a force, essentially a medial force to the first metatarsal. They wanted to find out, what would be the best fixation method to keep this loss of reduction from happening. And that was really the intermetatarsal screw that provided the best maintenance of reduction in both the coronal as well as transverse planes. And so, we talk about an intermetatarsal and intercuneiform fusion. Again, I think intermetatarsal is easy to get, and you can get around the base of the first as well as the medial cuneiform with this approach and into the base of the second. And again, with a little extra effort, you probably could get into the intercuneiform area. And so when we look at this, one of our colleagues, Dr. Campbell, will rotate the metatarsal, essentially hyperpronate the metatarsal in order to get to that lateral portion of the first metatarsal. It also opens up the space at the base of the second, as well as that space at the medial cuneiform. And so you can prepare those areas. I usually do it with a curved curette, and then I'll also fenestrate the base of the second with the drill as I'm preparing the joint. So, one of the other things about this is this anti-drift bolt trajectory. Again, I also discussed that, this is important as far as the intermetatarsal screw. So this goes from the first metatarsal through the plate and then to the base of the second. But you'll also notice as you do this that the guide directs you dorsally slightly, and that's because the base of the second, as well as that middle cuneiform, there, as far as in a dorsal to plantar plane, is much smaller. So you need to plan for that and go slightly plantar to dorsal with that screw. I'm going to return this back to Dr. Miller. I think we have some case reviews to go through.
So this is a simple one of a 53-year-old lady with midfoot arthritis. And again, sometimes we're dealing with bunions, sometimes we're dealing with midfoot arthritis. And you can see that her IM angle isn't too bad. She doesn't have any pain from her bunion. The question is, do we even enter into the distal first MTP joint when all of her problems were really 2 and 3, but she had some pain at 1. And so I opted for a 1, 2, 3 TMT arthrodesis. And when I do this, I prepare, I open up all my joints at once. And because I find once I have 2 and 3 free and I've prepared the joint, it's easy to reach around to do 1 and prepare the base of 1 and make sure I get all my junk out of the joint, as it were, so I can get a nice clean arthrodesis and a nice clean fusion. And this one, this was a little while ago, so I used the old medial plate, which I still like to do. I did not use a bridging screw from 1 to 2, but you could. But I chose this one because this was one of the prototypes of our 2-3 TMT plate that's now readily available. I want to show that she healed up beautifully at 5 weeks. I let her go to full weight bearing without much of a difficulty, and she's without pain and walking now fine with no problems at all. You can see I did do a silver type release on the first med head, because she said, oh yeah, that is hurting me a little bit, but I didn't do much of a release, and I think she's pretty happy with that. If she had more problems there, I would have done an Aiken, but there was no need to. So on this one, I did not do a lateral release. And I just want to show one of the early uses of this, one of the prototype plates, and it's working quite well. Any thoughts from anybody?
Did you use the cut guides when you did this?
I
Dr.
did.
Miller?
So we're going to talk about it a little bit later, but I do a lot of teaching with residents and fellows, and I started using the cut guides. I used to show how cool I was by doing my freehand cuts and teaching people how to do it. And guess what? The cut guides are better. They make my case a lot easier and a lot faster for me to do. And I find that they're kind of fun. It's kind of straightforward and takes a lot of guesswork out of reducing these joints. And so I'm now a big fan of the cut guides. And that's from a dinosaur, so you should be happy. Okay, let's go to the next case.
Looks like one of mine. Oh yeah, so this is a 44-year-old retired military. Now she works on her feet all day long on concrete floors in a warehouse. She came in with sort of vague midfoot pain, and I noticed the diastasis between her first and second raise, and that was like the first thing that jumped out at me. But we ended up getting an MRI, and she had absolutely no inflammation in that area. She had an intact Lisfranc ligament. She didn't have a lot of instability locally there, but she had a lot of arthritis on her MRI, surprisingly at the navicular-cuneiform joint, especially the medial NC joint, and then at the second and third TMT, which really on the x-ray I didn't appreciate, but on her MRI jumped out at me and was really bad. So go ahead. So we just focused on where she was having pain, did the DynaMet system and just used 2 staples on the midfoot, and then did her NC fusion using the CrossRoads Crossbar system, which is a really nice system. And that seems to have eliminated her pain. I couldn't believe she came in. She was already walking on it at like 3 weeks post-op, and I was, got onto her for it. And she was like, "Why would I stop? It doesn't hurt." So really impressive. I did do a sort of a modified hook test on that first ray because I just couldn't believe that there was no instability there. But sure enough, it didn't budge. So I didn't really want to add hardware to something that didn't need it. Plus, if you're using staples, I have a hard time throwing a bunch of screws across these joints or in between these staples because I just don't want to lose that dynamic compression ability. So I stuck with this. I figured, worst case scenario, we could do a first to second fusion later if it bothered her, but with no bunion deformity, I wasn't really worried about that. I was just trying to get the joints fused. So worked out nicely. I think in this one also same as you. I think I would prep all 3 joints first. Even in this case, I think I prepped all 3 joints first just so I don't have to worry about prepping after I've fused a joint. And then I think we ended up putting the rack block on the third to compress, and then putting the staple on the second, and then we put the staple on the third. So kind of an alternating technique just to try to get some compression when you're putting the staple in.
So there have been some studies that show that the plate with a staple is probably going to be stronger than just a staple itself. And I think that remains for us to test a little bit more. I used to like these staples, and now I'm using the staple plate. I think it gives me a little bit more stability.
Yeah, I agree. I think, I guess I haven't seen these go wrong yet. So, you kind of stick with what works until it fails. I'm sure I'll have one come back in, and maybe it'll be this one eventually, who knows? But to this point, I think the way I think about these, it's a race against, it's a race for fusion or hardware failure, whichever one comes first. So, in my opinion, if we can get this thing to fuse, it doesn't matter what hardware's in there. But now if I'd have known she was going to be walking all over it, I probably would have changed, I probably would have put a plate on there. So.
Scott, what's your feeling about intercuneiform fusion?
I think that it can be beneficial, especially when you're looking at severe intermetatarsal angle, something like that. I don't do a lot of intercuneiform. I think I can't remember between John or Bohe and Anderson which one does the intercuneiform and which one does just the base. I don't think that they're completely necessary. Many times I'll just put a screw across and that seems to be fine.
Oh, this was my case also. This was the first time I ever used the DynaMet system. I was a patient with a nasty bunion. Also, as you can see in the clinical picture, I was really impressed with the DynaMet cut block, and that's the wafer of bone that it took off. I mean, you're talking about all the cartilage and just a shaving of that subchondral plate, which is really an impressive cut. When try to do that without a cut guide, I dare you. The other thing that's really cool about this, when you open it up after you've made that cut, is you can look all the way down to the bottom of the joint with that Hinterman distractor, and you can see that you've got a nice flat plane cut with two opposing surfaces. You don't have to worry about, did I get all the way to the plantar aspect of the joint? You don't have to worry that it's angulated, so you're going to get dorsal or plantar angulation of the metatarsals. All that stuff's kind of taken care of for you with these cut guides, which is really handy. So here's just running through the case. I just saved all the images. On the far left there, you can see all the joints have been prepped. And then we put the plate over we tried a couple different plates. You can see that we tried the offset on the second, and then we switched over to the offset on the third. Just liked that contour a little bit better after we got to putting the plates on there. Then you can see we've got all of our pins in for the DynaBunion correction at the same time. Went ahead and fixated 2 and 3 first, just like the technique guide would show. And she had a lot of metaductus, so I went ahead and, instead of putting that second, or the hook around the second metatarsal, I decided to put it around the lateral aspect of the fifth met on just externally, which I've done a couple of times. Once you get that DynaBunion corrected, you see that plate going on. Let's see, go ahead and head to the next one. I think we've got finals on the next slide. Oh yeah, clinically you can see that bunion was a whole lot better. Wish I would have gotten that hallux a little out of valgus, but she was extremely happy with the result. Oh, I thought we had x-rays of that, sorry.
I think if you go right,
Yeah,
there
we
you
go.
are.
So yeah, here's the final construct. The hard thing here is, how do you, when you're putting these staple compression plates on there, where do you put these screws that go from 1 to 2 and stuff like that? I just try to stay outside of the staples and put the lag or the anti-drift bolt in there last. I think as long as you do that, you're staying pretty safe. You're still able to get your compression. It may restrict a little bit of the compression, but I can't see that it's going to stop it altogether. With that screw going across there, as long as it's extra articular and not between the staples.
All right, so this is a young man that had a Lisfranc injury. He was on a four-wheeler. What we don't see on the CT scan is that the second metatarsal was almost completely dislocated dorsally. It's just we only have the cut of the first TMT joint there. I'm trying to go to the next one here. So we ended up going through and doing a medial approach for the first TMT joint, and then 2-3 approach to come in and reduce our fractures, and then place the 2-3 staples. I would love to be able to use the new plates that we have for these TMT fusions, but none of the hospital systems that I'm at right now will allow any new product to come in. So I'm very restricted on this sometimes. But we went with the Hymax Plus staples for the 2 and 3. I've since seen him back. He's completely fused. He's about 3.5 months out and walking in a regular shoe.
Hey, Scott, did you graft him?
So for this kid, I did take a little bit of calcaneal autograft, and mostly it's because he had a plantar fracture of the base of that second, and so I wanted to put a little bit more bone in there for grafting. So going on, this is a lady with metatarsus adductus. You can see that she's has it severe enough that she's ended up with a stress fracture of the fourth and now a a stress fracture of the fifth. And so we went after this case trying to reduce the adductus, also provide her a more stable medial column, and then address the fourth and fifth at the same time. I'm just trying to see if I can go to the next slide here. Can you go to the next slide? So what we ended up doing with this, so we came in, we did cuts at the base of the second and third in order to address the alignment, also prepared our cuts at the first, and then came in at the end of the case, came down to the fourth and fifth, did a resection arthroplasty, and through that resection arthroplasty, put a screw across the fifth metatarsal stress fracture, and then did an interposition with an allograft into the fourth and fifth TMT joints. I do have some x-rays that I'll need to get for the next presentation that show her later on follow-up.
Okay, so now we're just going to go through some of the basic algorithms and just thought processes, and we'll kick in with basically the algorithm for what do you do for your bunions? When do you go distal, proximal, or what do you do MIS, or what my MIS is the mini bunion now. And I thought I'd start off with Evan and tell me what your basic game plan is.
Yeah, and I wish I could give you a, this is when I do this is when I do that. Unfortunately, a lot of this is just kind of what works in your hands and what, and I probably use each one of these systems almost 33% of the time. I really do. It's really amazing how, I'll do 4 or 5 DynaBunions in a row, and then I'll do 4 or 5 mini bunions in a row. It's just, I think mini bunion is great for a flexible, mild to moderate bunion that is easily overcorrectable because you can kind of get it realigned and repositioned just perfectly. If you've got any stiffness in that MTP joint, I immediately start thinking MTP fusion. If crepitus pain, I don't know. I have such a lowered affinity for the mini bunion when that joint is stiff. I just feel that I have a better result and more reliable with the fusion. And then the DynaBunion, obviously, if you need a bigger correction or hypermobile joint, that's the time to do it.
So Evan, I had a question on that. With a mini bunion, I don't open up my joint very much. I don't look at my first MTP head like I used to with the chevron. And so I'm worried I might be missing some of those arthritis cases. And it should have probably gone to a fusion, because we all know when we used to open up some of those chevrons and, oh, look at that, I guess we're doing a fusion instead. And I worry I might be missing it, but I haven't had too many complaints yet. What's your experience?
Yeah, that's why I squeeze the joint in the visit before surgery, in our surgical discussion. I'm squeezing the joint, I'm putting it through range of motion. I realign the hallux and then put it through range of motion, because I want to see if when I fix that deformity, what's it going to feel like? So I like to do all that kind of stuff. And if the patient is not tolerating it, or if I can't reduce it, or if I try to reduce it and they've got this big hypertrophic bone on the medial aspect of the first met and you can't reduce it fully, I mean, those are all signs that I'll tell the patient right there, I'm like, listen, you might not get the result you want, or I might even tell them, I don't think I can do this without doing an Aiken as well. And so I'll just kind of get that discussion going as well. So there's a lot of, but I mean, obviously MTP fusions, if you've got a wide open joint, it's hard to talk anybody into that. And I shy away from it, but if it's painful and you can't reduce it, then that's a good option.
Hey, Scott, has the mini bunion expanded your repertoire for how high an IM angle you can go?
Yeah, so I had used the isoplate for quite a while that OrthoHelix had put out. And so I thought that that had really expanded my ability to address higher IM angles with a stable first TMT joint. And you can even, rotate, you can rotate it out of pronation with this technique because you're using a transverse cut. And so, this is just an extension of that, or, continuation of that, just a smaller incision than I used to use with the isoplate. The one thing with the mini bunion, though, and again, we're talking DynaBunion and DynaMet now, but the mini bunion is, because I'd had that experience with the isoplate, I kept making my cut too distal on the metatarsal. This cut really is at the kind of the metatarsal neck head junction, or maybe even slightly proximal to that, so that you get the plate to actually sit down behind that medial eminence. And then you can get the rotation, and I've really liked it overall. Again, one of the other things is that don't forget that you can redirect that distal locking screw to get into the head better if it's too proximal, etch or cut, those type of things.
Okay, good. Yeah, my own process is, if I have instability of the first MTC joint, I'm going with the DynaBunion. So when we're doing our Lapidus procedure, how often do you do an Aiken? How often do you do a lateral release? How often do you do a gastroc side? Scott, how often are you doing an Aiken?
It's all case by case basis, and again, it's after I get my reduction and have fixed everything proximally, I'll look at it both clinically and radiographically. If there's a large amount of delta phalanx, or I just can't get the overall, even though the joint's aligned, but the toe is still going over, then I'll add an Aiken. And I love a minimally invasive Aiken. I just can't always get that instrumentation, but I'll still do an oblique cut and put a screw in it usually at this point.
That's what I find I'm doing. Even though the x-rays look a little funny, the patients are very happy with their clinical result. Evan, how much is the big toe able to touch a second toe before you jump into an Aiken?
Well, if they're, on the table, I kind of live by that. If you don't like it on the table, you're really not going to like it when they come to your office. So yeah, if I can get just a few millimeters of a gap between 1 and 2 without doing any of these procedures, I'm probably not going to do anything. But one of the things that I really have come to start evaluating is where the extensor hallucis is sitting over the top of the MTP. Because if it's sitting lateral to the MTP, you can pretty much guarantee that's going to have a lateralizing force, and it's going to keep pulling that hallux laterally. So I try to, if that's the case, I'll do an Aiken. If it's really far, definitely an Aiken. If it's kind of just lateral to midline, sometimes I'll try the lateral release alone. I'm almost not ever doing a McBride anymore. I think I've done 2 out of the 50 to 100 DynaBunions I've done. So that's really a sort of a fluky thing. And then, for gastrocs, I pretty much only do that if I'm doing the midfoot fusion and as a flat foot reconstructive type procedure, or if they have a severe equinus. But most of the time you're doing that to stabilize the medial column, and then you're adding the gastroc to help with that.
Well, I think that's very important to point out. The gastroc is, don't forget that you're doing a midfoot fusion and you've got tight gastrocs. You're going to be lever arming on that pretty darn hard as they start to recover and start walking on it. And I can't remember ever being unhappy that I did a gastroc. I just do a simple strayer. It takes me 5 minutes, and it definitely cuts down on the force that they're seeing in the early post-operative phase.
Yeah, I don't hesitate to add a gastroc either. So Evan, just are you doing a percutaneous lateral release, or how are you defining this between a lateral release and a modified McBride?
I guess McBride, I'm talking about like opening up the medial capsule and shaving down the met head, would be kind of my thought. Lateral release, I'm just percutaneous 6400 blade, going right in at the joint and kind of sweeping around the lateral flare of the proximal phalanx, just doing it that way.
I do my lateral release I do mine open still, I make a fairly generous 1-2 centimeter incision so I can see everything. And if I ever do, I'll do the ligament, but sometimes I'll do the capsule. I'll do a long slide along the met head rather than the transverse cut across that capsule anymore. It's kind of a long slide down approximately to just free things up so I can move it around. So how often do we see lesser TMT arthritis with the hallux valgus? I see it a lot, but I've got a kind of middle older age population. You gentlemen have the same thing?
I absolutely see it, especially when you get into metatarsus adductus. You know, I think that you get a metatarsus adductus patient, they're at much higher incidence to have second and third TMT arthritis.
But I like it when that happens. That way I can do a 1, 2, 3 and correct that adductus at the same time. And I think they're pretty happy with that. You pointed out for the second TMT and third TMT, you get a straight cut straight down along the proper plane now, and life is just better. It's just easier for me. So I've been a big fan. I started with the DynaBunion, and now I believe for all these it works very well. Any other thoughts?
Yeah, I can't tell you how many times I've dorsally angulated a metatarsal on a midfoot fusion because I didn't do a good enough plantar dissection or plantar joint prep. You know, which is not a bad thing per se, but if you get it up too far, all of a sudden you've got, you know, toes are plantar flexing and everything else. So it gets kind of funky, but you know, you do reduce some of the force by dorsiflexing, but if you can keep that alignment where it should be, you know, and then just add a gastroc, you should be fine as far as too much plantar pressure, I would think.
Yeah, so I've been doing freehand cuts for quite a while, but you know, and we have new fellows that started last Monday, and you know, first day, you know, letting them, you know, without having seen them at all, that's always a little bit hairy. Cut guides help that a lot.
So we have there's a question we had before about, or we have coming up about, if you have a lot of arthritis, sometimes make sure you take down some of those osteophytes before you put your cut guide on. It'll make life a lot easier for you.
Yep. Yeah, just a simple runger, plane it off and pop that thing in.
Philosophy on bridging versus fusion, Liz Frank. Well, since I never do bridging, I always fuse them. If it's a simple Liz Frank, I'll do a mini tightrope, but 9 times out of 10, I'm fusing them with anybody over 40 or 50. Any luck with bridging on any of these? My partners like it, but I never do it.
Yeah, I only do it in young patients without any evidence of fracture. If there's a fracture, intra-articular fracture, then my preference is a fusion.
Yeah, I mean, intra-articular fracture kind of changes the whole name of the game for me. But if it appears to be extra-articular or ligament only, I'll try to bridge. You know, luckily I haven't had to do too many of these in the past couple of years, but when I first came out of practice, I felt like the Liz Frank king of Fort Smith, Arkansas at one point.
Well, I'm definitely a big fan of fusion when you've got that interarticular fragmentation. They do so well with the fusion and so poorly otherwise. I think it's the way to go.
I don't think you're wrong either way, but yeah, I agree with you.
Okay, 4-5 TMT. I've been a huge fan forever of never fusing 4-5 TMT. I do a resection arthroplasty. I take, I leave about at least a couple millimeters off of each side. And I put something in between to fill the gap so it doesn't fuse across. Anybody fuse 4-5 TMT?
Absolutely not.
Good.
Oh, never have.
So I was the guy that got assigned to do the interpositional arthroplasty paper for Bob Anderson when I was in fellowship quite a while ago. So I looked at a bunch of these, and then, you know, you can't use the ceramic balls anymore because those have essentially gone away. So I've gone to the same thing as we already alluded to in the previous case. I resect it, and then I'll put a tendon allograft anchovy into the space. Are you doing like some sort of other graft, Dr. Miller?
No, actually, I use TinaGlide. I published that once before. Integra makes a tendon wrap called TinaGlide to help things from sticking down. I just accordion it and stick that in the space, and that's worked well over the past 10, 12 years for me. The trick is taking enough bone and you really have to do a generous resection. I did one yesterday with a 1, 2, 3 TMT, and 4 or 5 were just nasty. I did a separate incision to get to them, and I resected probably about 2 millimeters on each side at least. So the big gap, maybe more. And I had one in 10 years grow back over, kind of scarred over, that I had to redo. Now the hard part. Do you let a Lapidus walk on their heel or not at all?
I usually let them walk to an extent. I tell them try not to go crazy. You know, you can walk around your house to use a restroom or get a bite to eat, but other than that, sit her down with the foot up. It is funny. I don't think patients who are reasonably trying to limit their walking, I don't think there's a big difference between people who limit their walking to a degree and non-weight bearing at all. I think it's the people that are really crazy and go nuts and walking all over the place. Those are the ones that typically have problems. But I haven't seen a lot of them, especially with this system. And maybe that's joint prep, maybe it's the compression, maybe it's 100% bony apposition. I don't know which of those it is, but it sure seems to be working.
What about North Carolina?
So, you know, it depends on if I'm doing a 2-3 in addition. If I'm adding that, I'm putting them in a split and keeping them non-weight bearing for a couple of weeks. And then going into a boot at a couple of weeks and let them, you know, set the weight of the foot down. I'm a little bit scary when I resect more or do more midfoot fusion. And then if they've had a gastroc, you know, I'll cool them down for a while. If they're just the DynaBunion first TMT fusion, I'll let them put weight on their heel right away. But limited walking, you know, just for limited need, and then start weight bearing in the boot at around 2 weeks.
I agree. I put some of my older patients, some people who are a bit more frail, I'll put them in a walker boot versus a post-op shoe. I don't really know the answer, but I've been getting much more generous with letting them do some partial weight bearing, and I haven't had any problems yet. So it's an ongoing question mark that seems to be quite varied.
You know, I think if we look back, and Dr. Miller, not to point out your age, but you're old enough that you remember, you know, Lapidus fusions. When I was a fellow, you were at Union. You know, I only did one Lapidus fusion my whole fellowship year, and that was because everyone was so scared of a non-union at this joint. And so I think things have changed with instrumented fusions quite a bit, and we'll continue to see how this evolves.
Oh, it's amazing. I do, you know, again, I used to hate doing a Lapidus because the Lapidus was hard. You had to get your cuts right. I saw so many complications from it. And now we have much better cut guides. We have much better instrumentation. It's turned into a much more reliable procedure. And I do a ton of Lapiduses now that I think I should have been doing in the past. And I've been converted by some of the giants in the field who are doing a lot of them and showing us how to do it and let them do it a little more generous with some partial weight bearing. So I agree, things have changed.
Yeah, my biggest problem with it was that it took 90 minutes or more, even if you were well skilled, if you wanted to use a plate. I mean, you could throw some cross screws in there pretty quick, but you know, or however you wanted to do it. But if you wanted to use a plate, sometimes those systems get kind of complex, you know, big planar incisions and all sorts of stuff. You know, I think this system does a nice job of keeping the incision small and still having reliable and fast. You know, I don't know very many people who are doing Lapiduses in 45 minutes like we can with this system. So
yeah, goes real easy. Questions and answers. Do we have some questions to do?
Yes, we do have a few questions in. Thanks for all the great insight you guys have provided. First question is, what is the role of capsularity versus lateral release?
So I don't do a capsularity anymore. I had a couple of hallux varices, and so I say that only for my real bad cases. I'll do a lateral release a little bit more regularly, depending on how the seismoids come over with a rotation.
yeah, I haven't done a capsularity in 2 years. I don't think so. I basically don't use them anymore. I haven't found that I need them. Now with the mini bunion, you do have the option to percutaneously tighten the medial capsule with the loop, and I will use that a great deal. But you're not really permanently tightening the medial capsule. You're really just kind of temporarily providing relief from the lateral pull of the hallux, in my opinion. So I think it does a great job of helping provide stability during your immediate post-op phase. But as far as, permanently tightening the capsule, I don't think I've done that in a long time.
Yeah, I don't really do a lot of medial capsule, but I will add on, in some cases, a small, minimally invasive technique with a zero vicryl, similar to with the mini bunion, to just give me a little more correction if I need it.
Great. And we had another question that came in. Do you all ever worry about a construct being too stiff, rigid? I've heard someone say a staple plate combo seems too stiff. Thoughts?
Oh my gosh, no. The staple plate has a little bit of flexibility to it, and it's actually compressing across your fusion site. It's exactly what you do want. If you put locking screws on both sides of a fusion construct, I'm still somewhat against that. That would be too stiff. But with regular screws, non-locking screws, and the staples, you've got just the right amount of flexibility to get a dynamic fusion.
Yeah, I've done probably somewhere in the neighborhood of 50 to 100. I couldn't tell you, maybe 75 DynaBunions at this point. I've put the anti-drift lag bolt in probably 90% of them. And I've only had one or two patients that complained about stiffness. And even then they just said they would let me know if it didn't get better over time. And I haven't heard from them. So I think it's one of those things that we get a little bogged down in overly stiffening. And if anything, this is a less stiff system with the plate and screws, like Dr. Miller was just mentioning. So I think anytime you put a screw across a non-fused joint, you can get a little bit of those sorts of issues, but I really haven't. I've been pleasantly surprised that I haven't had any problems with it.
I continue to use only non-lock screws with this. I think it's the best option for this. You need to allow that staple to work and the plate in order for that staple to work. So when you get two bony surfaces that you're trying to fuse together, you get some osteolysis, which is where the bone resorbs slightly. And what that plate and staple construct allows to happen is for that compression to continue and for you to get past that osteolysis.
Another question for the group that came in is a great presentation. Thank you for sharing your expertise. Are you all seeing patients for these procedures for their first post-op visit at 1 week or 2 weeks?
So I see everybody at 1 week post-op, and I don't get x-rays then unless they've been knuckleheads and walking on it too much. But I just change their dressing, get a new dressing on it. I see them at 4 weeks after that. That's when I take x-rays and I see how things are doing. But I use monochrome skin, so I don't have to take any skin sutures out.
Do you use a running sub-Q monocryl or a skin monocryl?
I do a running horizontal mattress. It's been
Okay.
absolutely wonderful for the past 5 or 6 years.
Yeah, so that's what Hodges does, and he does warm soapy soaks, is what he says. I see everyone at 1 week also. I want to see them and change that dressing and rewrap them at that point.
Yeah, when I was in working for a hospital system and I had a large staff helping me, I would have them come in and have the nurses check on them, change their dressing at 1 week, and then I would see them at 2 weeks because I wanted to see if it was. I use nylon sutures, so I wanted to be the one making the call as to whether or not the incision had healed enough to take them out. But that was just my own personal preference. And then I usually see them again around 5 weeks. Depending on, mini bunions, definitely 5 weeks, sometimes 4 weeks. And then DynaBunions 5 or 6 weeks to start checking bone fusion.
So I'm going to put a plug in here real quick for everybody that I do a fair amount of medical legal work. And I know you don't get paid for seeing the patient in the post-operative period, but that first week is when they need to see you. And they need to be reassured that their foot looks good and that they're healing well, and simple questions are answered. And don't have them see your PA or nurse practitioner. You see them, put your fingers on their foot and tell them they're doing great. It makes a huge difference with their relaxing with their post-operative course. And that's why 1 week is great, because that's when they're scared. And you release some of the tension there. It really does a great deal to help with physician-patient relationships.
It's a great suggestion.
Great, thank you all. Last question is, Dr. Young, can you elaborate on the crossbar technique you mentioned in the NC Fusion?
Yeah, the Crossbar is a great system that's sort of in its infancy with CrossRoads. And it's a nice, so that basically it was kind of designed for the midfoot, where you get into areas where you could have either weak bone or maybe over resected a little too much, and now your staple's not getting good purchase, or something along those lines. The other thing it seems to do is provides a more uniform compression across the joint surface. So basically what it is, it's two screws that are both headless screws, and and then the staple goes around those two screws and it compresses on the screws rather than just pulling the bone together. So I decided to try it out on that case because I needed just the NC joint fusion, and I didn't feel like putting a plate over it because I wasn't using any other plating options, and that really has done marvelously well. So
Yeah, the way I think of it is it's increasing the surface area that staple is pulling against.
yeah.
So it's decreasing the chance that staple is going to just plow through the bone.
Mm-hmm. Yeah, because if you think about those inferior most staple arms, sometimes in the cancellous bone, it could do that. So yeah, that crossbar fixes that problem.